Hello, everyone. Thank you for coming tonight. It's great to see you all. My name is Ann Galloway. I'm the founder of VT Digger, and I'm very pleased. Oh, that's so nice of you. Thanks. Welcome. I'm glad you're all here to hear a provocative discussion about a very vexing problem that affects this region, the state of Vermont, and the state of New Hampshire, and that's opiate addiction. Many thanks tonight to our lead sponsor, Dartmouth Hitchcock. We want to thank Blue Cross Blue Shield of Vermont, our supporting sponsor. And special thanks to CATV-8 for providing videography tonight, and for the Barrett Center for the Arts for this beautiful space. And finally, I'd like to introduce our moderator, Mark Johnson. Mark is a respected Vermont journalist. He is a 25-year veteran of a very important political talk show called The Mark Johnson Show, which most recently was run on WDEV. And we have the honor of having him on our staff at VT Digger. He's our senior editor and reporter, and he's the best interviewer in the state. So please welcome Mark for the introductions to our panel, and thank you again for coming.
Thank you very much for being here. Can we have one more round of applause for the chief, please? Thank you. And also, a lot of people at Vermont Digger really did a lot of work on this project. I'll get in trouble if I start naming them, but Diane Ziegler, Paivon, Luke Han, and Teresa, some really great work here. Let me just give you an idea of what we're going to do here tonight. We have 5 panelists that are here. Where they're going to be giving presentations. We're going to start with Mark in just a moment here, and then we're going to have our 4 panelists here. They're going to each give a 5-minute presentation. So let me introduce you to who we're going to be hearing from tonight. Dr. Mark McGovern is a professor of psychiatry, of community and family medicine, and of the Dartmouth Institute of Health Policy and Clinical Practice at the Geisel School of Medicine at Dartmouth. Bess O'Brien, who's sitting right here, is a filmmaker, second from the right. Annie Ramnesiano is with the Vermont Pretrial Services, a very important program that's being taken now statewide in the court system. Renee Davis is the Director of Substance Abuse and Criminal Justice Services. And Sarah Laros is kind enough to join us here, and she is just about to celebrate her 4th anniversary of sobriety. Yeah. So we're going to hear from Mark, then we're going to have our panel come up. They're going to give a 5-minute presentation, and then we're going to get to some of the questions that you folks sent in, and thank you very much. We got over 40 questions, and they were all really great, so I'm just hoping that we can get to as many of them as we can and really kind of have a robust discussion. So we'll start, Dr. Mark McGovern.
Good evening, everyone. Thank you to Vermont Digger and Dartmouth Hitchcock for inviting me to speak to you tonight. I'm honored. It's really great to see this many members of our community come out on this topic. My guess is that it's personal for everyone here tonight, even those of us that are in the clinical end of things. And again, I'm grateful for your being here. Many of you have seen the lights, maybe? Little mood lighting. Where's Sinatra when you need him? You've seen this image from the Rolling Stone magazine. Kind of powerful, I think. So, I always wonder when I am speaking to people who aren't in the profession that I'm in, what they know about the disease of addiction. And first of all, the etiology, what the cause of addiction is. So this is actually a course, and I'm going to give it to you in about 3 minutes. So there'll be a quiz, and see how you do after the session here. So it's a mixture of genetics, of stress, and exposure to the substances. Stress could be bad, stress could be good. There are protective and resilience factors that could ultimately lead to the outcome of addiction. The pathology, the thing that's affected by the addiction, is the brain. There are other organs affected, but primarily it affects the brain. That's why we like to do these substances at first, because they feel very, very good. They're very reinforcing. What symptoms come from the use of the substances are kind of radiating. First, they affect the brain, but then they radiate out. So first, it might affect what I do with my body. It might affect what I do with my children. It might affect what I do with my wife or my parents. Ultimately, it radiates out even further and affects what I do to the pharmacist or to the police department or to people who I don't even know. And in part because of the way the symptoms manifest themselves, the phenomenology of addiction is misunderstood. People look at those kind of symptoms and those kind of consequences and think, wow, that's a bad person there. They don't recognize that the fundamental changes to the brain are radiating out and causing those kinds of issues. Person with addiction is not, this is not their plan A in life. They're suffering. They sense that sense of misunderstanding. They themselves don't really understand what's going on with them either, because this brain disease is affecting their judgment and their insight. And of course, we know about stigma. The good news about treatment is that we have them. The bad news is that we have no cures. So we're going to talk a little bit about available treatments tonight. But I'm going to try to tell a little bit of a different story. I was told I had 15 minutes, so I thought, well, what's the most important story to tell? So this to me is pretty interesting. The top generic prescriptions, you see, I hope you can read this. Number 1, the most prescribed medication is Vicodin. So those of you that are investors. And really, among the list of the top 200, we have a handful of narcotics. Quite a list. Pain is big business. So of all the major disorders, from cancer to diabetes, to mental health, respiratory, pain is number 5. Opioid prescriptions, that list I gave you over the past 20 years, you can see that it's gone up. We have reason to believe that those numbers are going to dip because physicians have been presented with new guidelines for prescribing these medications, in part because of the consequence that brings us all here tonight. Many of you may have had personal experience with death from an opioid, family member dying. This is the map of the U.S. Those of you might be interested in Vermont and New Hampshire, the wrong color, right? It's not the right color in this case. Often we're the right color on health issues. In this instance, we're the wrong color. These shades represent the Northeast, and the Northeast, as you can see, has been particularly seriously affected by overdose deaths. Overdose death in Vermont, you can see, way back when, very little overdose death. The state is white. I'm not going to go so far as to say pure, but at least it's white. You can see here, 2014, high rates of overdose death. Bess O'Brien's going to talk about matters in the Northeast Kingdom, the subject of her film. Rutland County, particularly affected. Big change from what it was 10 years ago. One of the interesting things is the transition from prescription drugs, prescription narcotics to heroin. So the top line are prescription drugs only, and you can see that number is going down. This is national data. The number is going down, but you can see heroin plus prescription drugs are going up. Heroin only, just a slight incline. If we were to take this out to 2016, it would be much higher. We don't have those data yet, but we know it's continued to rise. Those are national data. What's happened in the Northeast is this. Prescription opioids have gone down. Heroin has surpassed it and gone up. So what we see is an increased use of heroin in our community. Does that come as a surprise to anyone? It's a faulty clicker. I think I might need someone to advance the slide from the laptop. This looks good, thanks. So what this shows us is that what's happening in Vermont. The overdose deaths have continued to climb like the rest of the US. Interesting data here show that yes, heroin is on the rise, but we also have this substance that should not be available in the street. It should be available to anesthesiologists in the operating room, called fentanyl. So as the transition goes from things that are nicely packaged in a pill or a capsule, quality controlled at places like Purdue Pharmacy, now we're seeing packages of white powdery substances, contents unknown. Fentanyl is on occasion in those packets and is associated with overdose death. Why the transition? Well, if it's not obvious, prescription drugs are sort of expensive, and we've seen the prices increase. You saw that market share. So guess what happens when people start to realize they can make money in pharma? Many of the preferred opioids are harder to find. There's been a pressure on the pharmaceutical industry to try to decrease abuse, so some of the formulations are making it harder, not impossible. Wiser providers, being careful about how much and how long a prescription for an opioid might be needed, from dentist to family practice to emergency room, and new prescribing guidelines in both Vermont and New Hampshire, which are in the right direction. Heroin, it's cheap, it's good, much better than it was in the 60s and 70s. If we inject it, we get even higher faster and make the most of the substance that we have. A lot of you might have an image, if you're my generation, you have an image of what a heroin user might be like. Previous era heroin users, young, minority males, living in the city. The new era heroin user is kind of like that, that can of maple syrup. It's a young, middle-aged white male or female living in a suburban, particularly rural area. Employed, got a job. So quickly to treatment. These are the 3 FDA-approved medications for treatment. There's many medications that are being studied. You probably have heard of naloxone. I didn't put that on the list because that's simply to treat overdose. These are the medications that are FDA approved to treat opioid use disorder, opioid addiction. So methadone is dispensed in very structured clinics with dosing observed. Buprenorphine, many of you know as Suboxone. is dispensed in primary care or psychiatry or community health centers, but has to be dispensed by a physician, and there are requirements for counseling and other support. A physician is limited in the number of patients he or she can prescribe buprenorphine to, starting out with about 30 patients, and after some experience can ramp up to 100 patients. Naltrexone comes in a few different formulations, but is really a blocker. It blocks the effect of opioids. So the two formulations, one is a tablet, and the other is an injectable format, naltrexone IM, extended release, otherwise known as Vivitrol. I think I need help with the, sorry. So I think, yeah, maybe it needs a battery. So Vermont's response has been, it's been great, actually. It's been a pleasure to witness. I saw Beth Tansman here, Pam Farnham here, connected with the Blueprint. I know there are many providers of services to people with opioid use disorders. We have a governor who acknowledged in his State of the State address that we have an opioid epidemic, went out on a limb. We have what's called a hub and spoke model, which is really trying to treat patients where they are. So patients with severe opioid use disorders are treated in hubs or opioid treatment programs. We have 6 of them in Vermont. We have 1 Habit OPCO in West Lebanon that's very discreetly placed. Habit OPCO in West Leb treats about 300 patients per day, give or take a few. Many of them are Vermonters. The Spoke, I referenced that earlier, is a general office-based opioid treatment program. So your primary care doctor could deliver buprenorphine, prescribe buprenorphine to patients in or her practice already. Vermont has also supported all of these efforts with money. Sometimes it's one thing to go out and have a summit and say, we care about this, and then go back to the chambers or the halls or the offices and job well done, but no money. This state of Vermont has supported these initiatives with actual improved financing and reimbursement payment for services. And also, for every doctor that treats 100 patients, he or she is provided with a nurse and a behavioral health clinician, either a social worker or a counselor, to help support good quality care for these patients. There's been a lot, and I'll show you some numbers on this, a lot of activities to increase access to these medications, which I underline there as a quantity. So we really want to, like if it were Ebola or Zika, we would want to inoculate people, we want to immunize people. So the goal is often to get the stuff that's helpful out to as many people as possible. In a practice, a complex practice like prescribing addiction medications, there's often a wide variation in quality, right? So some doctors might dispense the medication liberally without a concern about it being misused or diverted, without adjusting how frequently to see patients that may be more or less severe or unstable. So there's been a lot of activities. Dartmouth in particular has been involved in activities to improve the quality of this practice. I don't have a clicker anymore. So one of the really interesting things is to be thinking about addiction as a chronic disease that affects the brain. So you have diabetes, which is a disease that affects the pancreas. And we have different ways of treating diabetes with the expectation that a person may have to either take medication, in the case of type 2 diabetes, maybe take medication and really focus on a lifestyle change. Type 1, looking at a lifelong use of insulin, injectable insulin, to replace what the pancreas would naturally supply. So the idea in Vermont is that it's a patient-centered medical home around a chronic condition. So there's a specialty care provider, a primary care provider that work together So the patient might need specialized care, just like a person with diabetes might need to see an endocrinologist. But at some point, they can stabilize and be seen by their primary care doctor, or even better, manage their diabetes by themselves with check-ins or recovery checkups or status checkups quarterly or even annually. Community health team is a way of supporting the activities across the whole neighborhood of a region of care providers involved in this kind of practice. So it might seem like common sense to do this, but no other place is really doing this. So it's pretty remarkable that Vermont has stepped up in this regard. Next slide. So this is a slide that provided by the Department of Health that shows the change in the number of people who are getting methadone across the state of Vermont. I'm going to walk over here. So in January 2013, which is not all that long ago, there were less than 1,000 people on methadone in Vermont. And you can see right now that it's probably over 3,000 if we bring it to date. The Chittenden Clinic has increased their census a little bit. The big change is this, what is happening at Rutland Regional Medical Center, who opened up a hub, or OTP. That was 0 in early 2013. And now it's close to 300 patients. Next slide, sorry. So this is pretty interesting too. This is the number of doctors who've taken on prescribing the buprenorphine to the patients in their practice or in their community that have an opioid use disorder. So if I'm a carpenter and I don't want to go to a methadone clinic because I need to be on the job site, I'm relatively new to my opioid addiction, I'd love to see a primary care doc that I can see maybe once a week or even once a month if I'm doing well. This is a great option for me. I can get an effective medication, get a month prescription. I see the doc maybe once a month, and I keep my job, I keep my family. It's not a major inconvenience. So what we see here is a slight increase, not as big of an increase. You see these slopes of these lines aren't really dramatic like some of the other overdose death, OTP census, transition to heroin, prescriptions for opioids. These lines are kind of subtle, right? They're not massively significant slopes over time. Good news is they're headed in the right direction. Next slide. So there are a lot of places that need more of that kind of intervention. So the idea here is that the counties in Vermont that are in blue, we kind of have above average number of providers per patients with an opioid use disorder. Those that are in white, and there's only one, Washington County, is kind of average. And those that are in green, where we are today, Windsor County, lower than average. So those areas have a shortage of providers for patients with opioid use disorders. Next slide. So some of you will recognize this line, progress, not perfection. Have we made a big dent? A little dent? No dent at all. We've obviously made a dent, right? There's more patients being treated. Number of prescription opioids that are being dispensed are stabilizing, if not reducing. Overdose death, I think at least in Vermont, is stabilizing. Overdose death is complicated by, I thought I heard footsteps. Complicated by if people are using a benzodiazepine, that adds to the risk of overdose death. How long should the medication be necessary? So the first point is that the medication is not a silver bullet. These aren't cures. They're part of a program of options for people to get better. How long should the medication be necessary? We don't know. There's no science to that effect. We do know that when people are on the medication and come off, most relapse. But there are people that come off and don't relapse. What is it about them? There are differences in their brain, differences in their social support, differences in their motivation? We're trying to expand the number of providers that deliver this medication. And one thing that's really interesting is that there are few hospitals, and most doctors now work in hospitals, next to hospitals, around hospitals. There are very few hospital practices that have taken this on. It's really interesting. Why is that? So we also need to evaluate outcomes. It costs money. I do research, so we get money to follow patients. We have a grant now from SAMHSA. I see some of the team that I work with here. It costs money to follow patients after they start these treatments. So we really need to understand how many people are getting better and at what rates and at what cost. And the last part is that, you know, and I think we're going to hear a whole lot about it in a bit, but we need to think about this, a vision for recovery. These aren't silver bullets. This is not just medication that's going to fix everything. There's a mythology among patients that it is a silver bullet, but it's really about kind of keeping the door open for the other really important things in life, like being a good dad, or being a good worker, or being a good mom, or being a good brother, sister, parent, etc., with or without medication-assisted treatment. So I'm over my time.
Let's put it right there. It's a great place to end.
Thank you.
Thank you, Doctor. Thank you very much, Doc. I think that was a really good place for us to start, really sort of set some of that base there. We're going to now hear from some of our panelists here, and let me give you a little better introduction to some of them. We just heard from Mark. We're going to start with Bess O'Brien. Bess, as I mentioned, is a filmmaker. Many of you know her movie, The Hungry Heart. I really found to be one of the most profound movies on this topic. So she really knows her stuff and has been around Vermont. So Bess, take it away.
I love Mark. I was just actually thinking, I have a new movie coming out on eating disorders, and I was sad that I wasn't going to be able to do an interview with Mark on WDEV, but he's a wonderful, wonderful guy. Anyway, yeah, I've been making documentary movies for about 20 years, and one of the interesting things listening to Mark is that I actually made a movie in 2002 called Here Today. I was commissioned by a group of community members in the Northeast Kingdom in St. Johnsbury to focus a film on families struggling with heroin addiction, because believe it or not, in the early 2000s, some of you may remember, Vermont had a huge heroin problem. And it was during the time that Howard Dean was around, and in fact, one of the big struggles around that was that Dean did not want to open a methadone clinic. And people who were struggling with heroin addiction had to literally drive to Springfield, Massachusetts to get their methadone. And so we made this movie, Here Today, and it was a lovely little film that focused on amazing people who were struggling, families that were struggling with heroin addiction. We toured it all over the state. We showed it at the State House, and it helped push, actually, the opening of the first methadone clinic. We were very proud of that. But, you know, ironically to me, I finished that film. I went off and did a bunch of other projects over 10 years. And then in 2012, pediatrician Fred Holmes, who was a family doctor up in the St. Albans area, who had been going along in his merry way, being a pediatrician, suddenly one day found out that half of the people who were in his practice were actually addicted to prescription drugs. And being the wonderful guy that he was, he simply said, well, this is a medical issue, I have to deal with this. How do I do with that? So he got his license and he started prescribing Suboxone. And over a year, he essentially fell in love with these people and really learned a lot about addiction and ended up wanting to tell their stories, talk to a mutual friend of ours. They said, you should talk to Bess O'Brien. She's this filmmaker. She makes movies about different issues in Vermont. And he called me and I met him. And if anybody's seen the film, The minute you would meet Fred, you would, as a filmmaker, you would say, I'm going to make this movie, because this guy was fantastic, just a wonderful soul. And so in 2012, I started shooting this new film on prescription drug addiction. Well, guess what? As I'm sure Mark and everybody here would say, it's all the same thing. It's all opiates. One is grown in poppy fields and the other one is made in laboratories. But for me, it's been very interesting over these last 12 years to see Vermont struggle with a heroin addiction in the early 2000s, sort of raise consciousness around that, get through that. Obviously, it sort of faded away or faded down. I'm sure it didn't totally go away. And then in the 2010, 11, 12, prescription drugs became the big deal. Opiates, Percocet, Vicodin. And I guess what I want to just say in my little 5-minute thing is that I've been touring this film now for 3 years all over the country. One of the things that happened when we made The Hungry Heart is that we toured it all over Vermont. The governor saw it. He was so moved by the courageous stories in the film that it helped push him to do his State of the State on opiate addiction. And that was a big moment, because having a governor, first of all, announce to his entire state that there was a problem, that we weren't going to push it under the rug anymore, and that above all, it was a health issue. It was not a criminal issue, it was a health issue. This was a huge step forward. And along with his State of the State, what happened is the next day, literally, national press from all over the country descended on Vermont. Because how could the beautiful, pristine, Ben & Jerry's loving state of Vermont have a prescription drug opiate problem? And so since then, I have been touring the film to small towns, to New England, all the way up to Alaska, to Texas and Las Vegas, and you name it. And I can simply tell you that this issue is a national problem. It is a huge epidemic. And you know, when I go, especially into small little communities who literally are just, you know, blindsided by this and trying to struggle to figure out how to get support, how to get treatment. You know, it's something that Hillary Clinton, Bernie Sanders, and probably even Donald Trump, when he came to New Hampshire, had to deal with, because when they were in these town meetings addressing people in New Hampshire and saying, what do you want to talk about? Do you want to talk about, you know, the state of the economy? People said, no, we want to talk about the opiate problem that is tearing apart our communities. And so this is going to be a big issue in the presidential candidacy and campaign. And Obama right now, I think, is trying to push through a bill of $1.2 billion towards opiate addiction and treatment. So it's a big problem. We need to be coming together as a community. And thank you so much for coming out tonight and sharing your ideas and asking your questions. Thank you.
Thank you, Bess. We're going to hear next from Annie Ramnasianu, who, as I mentioned before, is with the Vermont Pretrial Services. This is a program that started up in Chittenden County and has been attempted to be expanded statewide, and helps people when they get arrested maybe go in a different direction than directly to jail. So, Annie.
Thank you so much, and thank you so much for hosting this event, Vermont Digger, and for having all of us down here. Building on what Bess said earlier, and I am going to keep my comments brief because we really are interested, I'm very interested in hearing your questions here tonight. I've had a passion for mental health issues and for addiction issues since I was a teenager. I grew up in New York City. I moved here about 28 years ago, and I saw the effects and the impact of addiction across all socioeconomic levels, all races, all levels of society. Left a lasting imprint on me, and I am devoted to this topic, and I have put my entire life work towards improving the lives of others in regard to these issues. When I came to Vermont, my goal was to become a licensed clinical mental health counselor and also a licensed alcohol and drug counselor. And I worked for many years in Burlington and Chittenden County, as Mark just mentioned. And I was the clinical director of an organization there called Spectrum Youth and Family Services. And we worked with teenagers and families around addiction issues. I've been very, very privileged the last couple of years to build on the governor's vision in creating innovative strategies for dealing with these issues here in Vermont. Subsequent to his State of the State, he helped to develop policy that became a law, Act 195, which included information about and a structure that gave birth to the program that Mark mentioned, pretrial services. So I have been serving in the capacity of statewide director for almost 2 years now. We are offering voluntary screenings, mental health and substance use screenings, for individuals who come in contact with law enforcement. The main group we work with are people who are cited into court. So people who are not detained and who are not incarcerated, who are cited into court. We offer these individuals the screenings, and we follow a protocol called SBIRT, which includes brief interventions, feedback, and connections to treatment and other social supports, whether it's getting health insurance or helping with housing, transportation. We help remove barriers, and we help connect people to the treatment services that they need. That most likely begins with getting a clinical assessment. The individuals have a second choice in this process, and that is to allow us to use a very high-level report that we cull from the information from the screenings, and we offer that information to prosecutors around the state. This is a statewide program, and every prosecutor has the opportunity to participate with us in this system. The prosecutor can then decide to use these screenings, the mental health and substance use screenings, and then also a third screening, which is called a risk assessment. The risk assessment helps us determine whether or not the person poses a risk of public safety by either failing to appear in court or recidivating again. So we try to, in this program, blend both a public health approach and a public safety approach, and help the criminal justice system with this information determine whether or not somebody would benefit from a mental health or substance use intervention, a public health intervention, or whether they need to have more secure measures, conditions placed on them to protect the public at large. The other part of this program happens at arraignment. At arraignment, judges also have an opportunity to consider this information and to impose what's called conditions of release. So the judge can hold them sort of in the supervision of the judiciary at that point and ask the person or order the person to participate in a clinical assessment and to follow treatment recommendations. They can also have the individual comply with what's called monitoring. The screenings that I mentioned earlier are actually delivered by people who are trained to conduct these screenings, and they're called pretrial monitors, part of the pretrial service delivery system. So we have developed this really caring collaborative across the criminal justice system, bridging to treatment providers. Renee is certainly involved in this as well. And we are doing our best to create open engagement, open communication with people who have contact with the criminal justice system. I'll add one more group. We also offer this service to people who are detained, but they are not arraigned yet. So that's the second major group. We have seen tremendous buy-in from the public in regard to these services. We've contacted about 2,500 people since this program was rolled out in October, and about 50% every month agree to volunteer for these services. So we have completed 900 screenings, and we are collecting a lot of data on everybody's needs, their risk, all of their issues. And we're really developing a compelling picture, state by state, county by county, across the state, that will help us deliver and target services where they are needed most, paying attention to cost effectiveness, the treatment need, and the types of treatment needed. So it's the first criminal justice public health data that's been collected in the history of the state for this population. And it's going to help drive, I think, the future of healthcare delivery and criminal justice delivery in the state, and is another great innovation that this state has undertaken.
Thank you very much. We're going to hear next from Renee Davis. She is the Director of Substance Abuse and Criminal Justice Services at the Clara Martin Center. She has extensive training in substance abuse treatment, correctional treatment programming, cognitive behavioral treatment, and evidence-based treatment practices for co-occurring disorders, which I know the doc knows about as well, too. So thanks, Renee.
Thank you. I first off want to recognize the turnout tonight. Fighting this crisis would not happen unless you all were here. So we need to pull together as a community, and what's representative here today is what needs to continue to happen. So I just need to set that foundation because it's been weighing on my mind just looking out here at the audience. So thank you. So who is Clara Martin Center? Clara Martin Center is a designated agency for mental health providing services, in addition to being a preferred provider of substance abuse services. So what does that mean? So that means that we receive referrals from people such as Annie, people within the DCF services area, as well as hub and spokes, primary care doctors, in providing treatment services. Clara Martin Center provides the outpatient level of care in addition to the intensive outpatient level of care of services. We assess somebody walking through our door to determine what do they need. We treat every individual as an individual. We do not look at somebody as a cookie cutter and say, you need this service. We look at what are they walking through in the door, what do they need for their services, and place them where they need to go. If that means they need to come into our services, we accept them. However, if they need a higher level of care or something further that we cannot provide, we are, in essence, navigators. We help them navigate the system to determine what do they need that we can't offer, connecting them with hub and spokes, connecting them with other services that we cannot provide. In addition to the treatment work that we do with individuals, we also do a lot of community work. After the Governor's Forum, we've been participating locally with other coalitions, trying to determine how can we fight this crisis. So we do provide the treatment end of things, but we also are interfacing with community members and other providers to determine how can we work together and what's the next steps. In addition, let me look at my little notes here. We're needing to look internally to figure out what do we need to do to broaden our scope of work. We cannot be treating people the same. We need to be broadening what we're doing, offering different types of services and different groups. Another great partnership that we have are with the Blueprints and with other primary care doctors. We have a very small spoke where our medical director is able to offer buprenorphine to patients, but we also work really closely with other doctors to help them prescribe as well. We provide the ongoing counseling and other services that they may need. Thank you.
Great, thank you. Sarah, you're up next. Sarah Laris, as I mentioned before, is coming up on June 9th, is going to be celebrating her 4th year of sobriety. I think we can give that another round of applause. She's the co-owner of Nutrition on the Green in Lebanon and is self-employed as a health and wellness coach, and she's going to tell us her story. Thanks.
Thanks, Mark. I first want to thank Vermont Digger and Dartmouth Hitchcock for allowing me to be here and having the opportunity to speak to every single one of you. This is a bigger forum than I'm used to speaking to, so it is a privilege to get my message out. So as you all know, already I am in recovery. And I have tried to get myself in the habit of considering myself to be recovered, not recovering still, because at a certain point in my recovery, I don't want to use anymore, and I have an extremely blessed life, due in part to when I was raised in a really, really awesome family. I was not raised in poverty. I was raised in kind of a normal, quote unquote, normal family atmosphere. My mom was a single mom and a business owner in herself. She owned a preschool for over 25 years. I grew up watching really good work ethic, going to school every day. You know, I have an older sister as well, so I was not only born and raised around here, but I went from the Lebanon School District to the Hartford School District in between my 6th and 7th grade year. And I was a sports player. I am a big fan of football. I was in theater, choir, band. I was a very well-rounded person in high school. One of the biggest things was that I was not that into academics. I was a very big social butterfly and absolutely loved every type of clique that you could possibly imagine in a high school. And so I was friends with everybody. And at one point, it kind of just switched for me. And I was dealing with an immense amount of emotions that I did not know how to process at all. I was kind of, you know, I love my mother. She is my best friend, but she kind of raised me to watch her not cry. I don't think I have ever seen my mother cry up until the day I told her I was a drug addict and I needed help. And at that point, I was 23 years old, and I started at the age of 15. So my mom watched me deteriorate throughout a number of different years. And I am a mom of an amazing 6-year-old. He's about to turn 7. He is the light of my life and the reason why I continue to be such a strong person. So I owe a lot of my recovery to him. Although when I was pregnant, I was still active. And in a sense of saying active, I was still smoking marijuana, which is what I first started with, and smoking cigarettes. I had stopped drinking, and I had stopped using any type of other substance. And so I am very blessed that when I did give birth, my son came out to be a healthy child. 7 pounds, 11 ounces, and he was just beautiful. So there are a number of different things that took place in amongst those years between age 15 and 23. One of which is that I became a mom, and at a certain point, I could not recognize myself anymore. And I went from using marijuana to prescription drugs to another kind of category of prescription drugs, which was Adderall, amphetamines. And then it kind of progressed, but we're here talking about opioids and heroin in general. And coincidentally enough, I started abusing Suboxone before I got into heroin. So it was my choice when I did get sober and go into rehab that I was not going to be on a maintenance program. And I was very firm about that decision as well, because I knew if I did really want to be sober, then I could not have anything. So I went for 30 days to Maple Leaf Farm in Underhill, Vermont, and absolutely loved it. It was a safe place for me, and I actually did not want to leave. I loved rehab, and not a lot of people can say that, but I did. It was a safe place. I made a lot of friends there, and immediately got out and went into the sober house for women that is in this area. And I know the director is here, and I have to recognize her, Sheila Young, because she is she's a recovery mom for me. And my mom, although is my best friend and she understands a lot and she did not judge me, we have the other aspect, and that's what Sheila took care of. She coddled me when I needed to be coddled, but then she was also firm when I needed firmness. She pushed me to go out and get a job and live life on life's terms. I was also diagnosed with manic bipolar while I was in rehab as well. So I was started on a really heavy dose of 900 milligrams of lithium a day and gained an immense amount of weight. So once I got sober, I gained in between a 6 and 12-month period of time, I gained over 150 pounds. And that was because I was just replacing one thing with the other. And this comes in part with what you had brought up, Bess, because I'm so interested to see that film about eating disorders, specifically tied into addiction in itself, because food is an addiction for a lot of people. And so I was eating a lot of my feelings. I was not necessarily seeing a therapist until I was kind of pushed to. One of my best friends passed away when I was 8 months sober. She was a rock for me in my sobriety. I did not know her very long at all, but when we did start to hang out, it was every day. So I do consider her to be a best friend of mine. She was also sober. And so I went to therapy at that point. So I was trying to do a bunch of different things, meanwhile, hold a job, which was difficult, but I still did it. And one of the reasons is because when I was in AA for a long time, and I have to thank AA for giving me a foundation to build my sober life on. They helped me learn how to love myself again and kind of find an identity of some sort, because I didn't know who I was. I knew I was a mom, and I knew I wasn't a very good one. Now when we fast forward 4 years, I am 27 years old. I own a business, a successful one at that. I was blessed to, a few short months ago, be asked to be a co-owner of an actual nutrition club. And one of the other owners is here, Kirby Lynch, so thank you very much. And the team at Nutrition on the Green has given me a different life where it's a professional one. I no longer have to have that feeling of shame and guilt and a burden on my shoulder every day, kind of looking over, because I do know that I'm sober. I do know that I don't ever want to use ever again. I could have died. As I'm sure a lot of you know, there are plenty of people that do. I consider myself blessed and lucky, and a miracle. I do consider myself to be a miracle. And I'm very proud of that. So anybody who would be talking to me in person would know that. So I think that's about it that I have, because I'm interested to answer questions.
Great, thank you so much. So I want to thank our panelists. That was really great. So a lot of you sent in some really great questions, as I mentioned, and I'm going to try to sort of summarize and get to a couple of the themes that some of you folks got to. I think the question that we got the most is this anger at the pharmaceutical companies. And I know there's a temptation here to be looking back and maybe something we can't do anything about, but it seems to be what everybody's interested in. You know, what do you talk about the pharmaceutical companies? Are they the people that should be blamed? Annie, let me start with you on that.
I mean, I certainly think personally and professionally there is a burden of responsibility that needs to be placed with the pharmaceutical companies. It reminds me of the trickery around, cigarettes causing lung cancer. There's wide medical knowledge, obviously, about how addictive these substances are and the damage that they can cause. There's obviously also incredible evidence on the good that they can do, but there's a fine line. And I think that hand in glove with the pharmaceutical companies are the guidelines that we desperately need for the prescribing doctors on the receiving end of that. Because the consumer is the one who is bearing the brunt of all of these sort of misinformations or lack of information and missteps. I'd be curious to hear what Dr. McGovern has to say.
Me too.
Me too. And we know from the research that if somebody has been prescribed and has been a regular user of prescription opiates, that I believe the metric is about 40% more likely to be abusing more recreational opiates, heroin, et cetera. That's the jumping off point.
What do you think, Doc?
Well, you know, pharma is always an easy target. But I think, I don't know if any of you have had the privilege of being a hospital patient at any time over the past, 10, 15 years, but I have. And usually the first word out of the nurse that wakes you up and comes into your room is, are you in any pain? It's not like good morning or, you know, how are you feeling? It's, are you in any pain? And you could say yes, no. And on a 10-point scale, what is that number? So it turns out that there's a lot driving the market for pain medications, including hospitals and other healthcare providers who are influenced by agencies like the Joint Commission for Healthcare that says pain is a vital sign. Mm-hmm. You need to assess pain, and if a person is uncomfortable, treat them. So pharma sees that need, and they deliver the products that people need. So the part that is more concerning is the awareness that certain, with the onset of many medications or the introduction of many medications, there's an assurance that there's no addictive liability, that this one is safe. I mean, yes, you're right about those other ones, but these ones are safe. And then slowly over time, and it's usually the doctors and nurses, actually, that find out, hey, this stuff is actually really good. I like this stuff. And it helps my pain, but it also helps my mood. It helps me relax. And then before you know it, docs and nurses are addicted, and we have the first sign that there's a substance that has addictive liability that's not mentioned in the PDR or the inserts for the medications. So the answer to the question is a great question, but I think it's complicated. It may also, I mean, if you could point the finger at ourselves, right? It could also be, we don't tolerate pain very well. We want relief. We don't think we should have pain or suffering. Maybe generations before, the pain threshold was a little bit higher than it is now. I have no data on that. But
When we all walk to school uphill, bare feet both ways. So Bess, what do you think of that? The people that you talk to, do they blame somebody else? Do they blame themselves? Who do they blame?
Well, first of all, I'd just like to say that one of the interesting interviews that I did after the whole governor's thing is a journalist came over from France, from Paris, from a newspaper there to do a story on Vermont. And she interviewed me about the film. She also interviewed the governor. And one of the things she said to me is, you know, it's one of the hardest things about writing this article for French people is that we don't really give these drugs out. Like, we don't really know what opiate is. Like, what is a painkiller? I'm like, oh, come on. Like, you don't know what oxycodone is? She said, well, I mean, we give them out to, like, people who are, have cancer and really, but essentially when you go to the doctor, you get extra strength Advil. And so that was an interesting moment. And then the other thing she said is, we also don't advertise. There's a law in our country where you cannot advertise on television. And we both looked at each other and I said, well, just turn on our television set. I mean, every other ad is, you should take this, you should take that. So I think that as a culture, you're right. I think that we have gotten to a place where people, I don't know, it's sort of a chicken and egg thing. People demand these drugs. A lot of people come up to me and doctors come up to me and say, if people come to my office and I don't give them a prescription, they feel like they have not gotten their money's worth. You also have a lot of people who come up to me after screenings and say, I took my daughter to get her wisdom teeth pulled, and the first thing they handed me was, a prescription for Percocet, and I said, no, thank you. And they said, no, take it. And I'm like, no, just give me extra strength Advil. And they said, no, just take it. So you've got this, circle thing. And I guess the last thing I would just say is that I do think that the Titanic is beginning to turn. It's a slow process, but I would also really recommend that medical schools actually teach addiction to their doctors. Because I have shown this film at a lot of hospitals and a lot of grand rounds, and I ask doctors, how long have you studied addiction? And they're like, oh, I think, second year of medical school, we talked about it, for 45 minutes. I mean, whatever. So I think that, we need to educate our doctors around addiction. It's a disease, and it should be seen as that.
Thank you for leading to the next question. We got a specific question from somebody who was actually at Dartmouth Hitchcock. It had cancer treatment, surgery, chemo, and then was put on pain medication. And cutting to the chase here, they felt as though once this crisis happened that they were being viewed differently and were shunned, and asked the question, what could be done for those of us who are not abusers, who have real pain issues? And also, how can you get people off of these medications and find substitutes? Let me have you handle that one, Doc.
Yeah, no, I think that, we tend to think in black and white, like on or off, good or bad. And I think in the case of cancer pain, whatever helps people to feel comfortable is just fine, and that's in the guidelines. How do you get people off the medications? Well, I think there are guidelines for that. So it turns out that many people with chronic pain could benefit from non-narcotic or even non-pharmacological alternatives. So mindfulness, massage, you mentioned cognitive behavioral therapy, turns out to be very effective, as effective for chronic pain as opioids. Now, the problem with CBT is that you either benefit from it or you don't in the field. So in other words, you're going to either get better or it's not going to work for you. And we don't really know who's a good candidate for it until we try it. Mm-hmm. But those, as a researcher, the effect sizes, the impact of those non-pharmacological treatments are just as effective. Mm-hmm. The other thing that often comes up with pain medications, and I have a colleague in pain medicine, David Dent, who's at DH, many of you might know David, will say that I actually don't want to treat the pain as much as I want to treat the person's quality of life. Mm-hmm. If they're pain-free but still on the couch and not working, are they actually better? So his approach is functioning. So what am I doing to help the patient function? And I think people that treat addiction think the same way, or they should think the same way. What am I doing with this medication to help a person function, not mm-hmm. just to not use another substance?
Is there a cookie-cutter approach to just sort of ratchet people off of these drugs? Is it the same thing for everybody?
No, everybody has their own taper.
Okay. Of course, one of the 800-pound elephants in the room, Bess, is what you talk about in your movie, which is, we're not always talking about pain medication to deal with physical pain from an injury, but things that are much deeper than that. Can you talk a little bit about that?
Well, I'm sure Sarah can, too.
Yeah, and she's next.
Well, I mean, I often talk about the name of my movie, which is The Hungry Heart, and I had a really hard time coming up with a title for that film, actually, and it wasn't until I was driving in my car one day and the song came, The Hungry Heart, on the radio, and I said, that's it, because I think so much of addiction, whether it's heroin addiction, opiate addiction, alcoholism, frankly, eating disorders, go down the line, it has to do with filling a hole. Mm-hmm. Not with everybody, but I think that, we all have hungry hearts. We're all human beings. I often say, I hope what the movie does, in a way, is humanize us all. Because, it's not like you're looking at these people and you're going, oh my God, they're so weird, they're from another planet. It's like, I can relate to that. I feel depressed, I feel anxious, I feel alone sometimes. We're all looking for love. We're all looking for something that's larger than ourselves. We're looking for something that makes us feel self-esteem in our lives. And one of the most poignant moments in the film is Fred, this pediatrician, turns to a patient and he says, I figured out the other day that I'm not treating addiction, I'm treating self-esteem. And it's like, to me, that's really the bottom line. And so I think that, yes, we go very quickly from, pain as in physical pain to pain as emotional pain. Mm-hmm. And these drugs are really good at helping you with that right away. then they turn on you and make your life hell. But, you know, there are people in my movie who say that first moment I took that oxycodone, man, you know, I was, the stars aligned, and I've never felt so good in my life. So I think we really need to treat people with respect around that. The last thing I'll simply say is that there's a wonderful guy, Gabor Mate. I don't know if you've read his books. He's a Canadian psychologist and doctor, and I heard him lecture at a conference I was at, and you know, he really talks about the fact that I wish we didn't call people addicts. I wish what we said is these are people who are dealing with emotional pain and trying to soothe it with some sort of chemical. And if we had that attitude, I think we would go a long way in treating these people with compassion. That's your in.
Thank you. So one of the biggest things that I have to tell, or had to tell myself and sometimes I still do, is that I am not a bad person trying to get good. I'm a sick person trying to get well. And that stems from a mental illness. With manic bipolar, even when you really don't know that you have it, you experience, especially in your teen years, you're experiencing the highs and the lows, and with manic bipolar, you're experiencing mania. So you're like super, super high and super, super low on a normal, on a normal scale. It's below what would be a normal low for depression, above a normal high for hyperactivity, and that can happen within an instant. So one of the things for me, I know something resonated with me when you said who do people blame? For me, it was anybody who told me I was an addict. Therapists. I tried to get a lot of help before I even got sober. They called me a junkie. And I'm not a physical person, but I can get physical. And that was not okay, because this was before I had even started using heroin. And number one, I can set the record straight, I've never used a needle, touched a needle in my life. And I'm very blessed for that, because if I had not chose to go and get help, I would have. I had people hiding needles in my house with their names marked on them in plastic baggies. The Valley News, I had an article written on me in the beginning of the school year, and I talked a little bit about how my people that I surrounded myself with, yes, they were my drug dealers, but they, even at the end of my use, had to cut me off. And my drug dealer actually recommended me to the rehab that I went to. So we have hearts, and we do care. We may not care much about ourselves, but we care about other people. And I can say that as a whole, because I'm pretty sure I have one of the biggest hearts that I've ever seen. And yes, it is hungry. And for right now, I switched. I went from being hungry to cover up that pain, no matter what it was, whether it was emotional, physical, doesn't matter, mental, to a hunger to feel amazing with getting healthy.
Thanks. I want to talk a little bit about treatment now, and actually I'm going to start back again with you, Sarah. You mentioned that you were abusing Suboxone even before you started using heroin. What was the treatment program you used to get off it, if any?
I actually had, towards the end, while I had switched from Suboxone to heroin, I then went back. I knew it was probably 2 weeks. I knew I was going to be going to rehab, and I had a dealer who was trying to give me Suboxone but then wean me off. And it was mainly a person who did not want to see me go down the path that I was going down, but he didn't want to see me in pain either. And so he would give me dose by dose by dose each day. So I do believe in some sort of maintenance program. I am also a recovery coach. I went through the Vermont Recovery Network Recovery Coach Academy, 30-hour intensive. It was absolutely phenomenal. Hannah Rose is amazing. I had a switch in a mindset, I guess, or an opinion. I had a very strong opinion against maintenance before this Recovery Coach Academy. I went and I have a different opinion, and that is if it is going to be managed so closely, which is probably almost impossible in my head, that people are not then going out and either A, selling it, or B, they're abusing it the way that I know people do, who are on a maintenance program, then it is helpful. It's so helpful. But I also know people who have been on maintenance for 20 years. And that, right, that's not a program. That's not weaning somebody off. That is letting them cover up their pain for life. And one of the things about being in recovery is feeling that pain and knowing how to process it, and knowing how to deal with it, and that there are different avenues to use that are not medicated. So,
Can you talk a little bit to that, Renee?
Yeah, different avenues I think sticks out to me. I think that we need to remember that, again, the cookie cutter comes to mind, is that every person presenting for services is presenting with something totally different than the first person in front of them. Somebody may need MAT. Somebody may have really strong feelings against MAT. Somebody may need residential. Somebody may need just an individual therapist. And I think that we need to have many different avenues for these people coming through the door. We need to be able to provide many different modalities of treatment to meet their individual needs. And if we don't have that available in-house, it's our job as treatment providers to find that for them. So having those different avenues, having the different modalities, and having the connections within the community and with the other providers to make those seamless transitions is so important for the overall care for these people.
I just want to chime in here. Having been a treatment provider for over 20 years and worked closely with Mark on a number of different research projects, and you touched on this earlier, we know what works. We know how well it works for different groups of people. What we don't know, back to your point, is what works necessarily for each individual. And that's a constant conversation between a therapist and an individual, setting timelines and outcomes and benchmarks to help the person see their own progress, because that can become an iterative part of their feeling successful and taking control of the direction of their life. And we need to know a lot more about the brain and how the brain responds to different medications and responds to different behavioral types of therapies. And I think it's our jobs as therapists to also help people understand that we can't tell them what to do. We can show them how to do it. We can listen and support them in how to do this new living, new lifestyles, new ways of thinking. But we don't have a silver bullet yet. And I think that's the frustration and creates the confusion about addiction treatment, is that you have a course of treatment and then everybody expects that you're cured and that it's over. But it's not. It's an individual, lifelong path of maintenance and dealing with all different kinds of pain.
Doc, you mentioned before about how many people relapse and they're not successful. We got a number of questions about specific drugs. We've heard Suboxone tonight. There were a number of other ones that people mentioned too. Is Suboxone today the gold standard?
It's one of three medications. So Suboxone is actually a combination of two medicines, buprenorphine and naloxone, which is meant to sort of limit the euphoric feeling that you might get from pure heroin. It's kind of a colleague of mine calls it like having the the governor on the gas, like the U-Haul trucks that you rent has a governor on it, right? You can, as much as you press the pedal to the metal, it's only going to go 60. So it's kind of a little bit like that. The other medication is methadone, which is also what's called an agonist, and is also a treatment that's very effective, as measured by reduction in relapse, reduction in death, reduction in crime, some evidence for improvement in quality of life. It's considered a maintenance medication, not a medication to just wean off of heroin or a prescription narcotic. The third medication is naltrexone, either extended release or the tablet form. I mean the injectable or the tablet form. That's a third option. The differential about which medication is best for what person, we don't know a lot about that yet. I think the general feeling is that naloxone or naltrexone might be a reasonable place to start. And then if that doesn't work, then Suboxone might be a reasonable thing to go to. And then the third line would be methadone for the most severe cases. But people are still working on those kind of algorithms, and as everyone has said, the response is highly individual.
Mm-hmm. We had also a number of questions about synthetic heroin. What's your take on that? Does that make sense? Low dose. The idea is to keep people on a really low dose, but to keep them from, having the addiction withdrawal.
Yeah, I think all of them. I mean, any opioid can be used for that reason. Can be used as a kind of a detoxification or taper to get off the other drug if monitored carefully and safely. That's certainly an option.
Mm-hmm. Bess, why did most people relapse that you talked to? Because there's no drug for the hungry heart.
It's hard. It's hard. It's hard. It's hard. It's hard. I mean, I think that, what I would say to that is that I think that, we often talk about recovery in this sort of vacuum. I mean, you can't be in recovery unless you have housing, unless you have a job, unless you have money, unless you have people that are wrapping around you, that are supporting you, unless you have something in your life that is somewhat meaningful. I recall another scene in my film where one of the kids who Fred sees, the pediatrician, is this homeless kid on a bike. And, he says at one point, you and I get up every morning, we get dressed, we've got our schedule, we get in our car, we go get our coffee, we do this, we do that. We've got things to do all day, we've got places to be, we've got things to do, we've got hopefully people who care about us. Stevie is homeless, he never graduated from high school, he has no parents, he has no money, he's sitting in some room somewhere all day long, and we're expecting him to get clean? I mean, what? I mean, if I was in that situation, I'd be getting high. I mean, why wouldn't I? So I think that, part of what we really need to be talking about, and Annie knows this, all you guys know this, is that we really need all our systems working together to wrap around people in recovery. Because recovery is not just taking a pill. I mean, Suboxone is a very important tool in the toolbox for some people. It helps some people very much. But if you're not changing your people, places, things, if you do not have people in your life that are supporting you. The kid in my film that was sort of the poster boy for recovery was Dustin, the farm kid. And, he's still clean 7 years later. And why is that? It's because he has a farm that he can go work at. He has a really committed family. He has a wife now. He has a kid. He has Fred. He has money in his pocket, something to do every day, and he has people who support him and care for him. And so if we don't have those things for people, or if there's the last kid I will think about in the movie is the kid who comes out of jail and is on furlough and is living in a halfway house and is trying to deal with his addiction, and he's trying to get a job, and good luck with that, that's really hard. Mm-hmm. And, one day he gets depressed and he relapses, right? And the first thing he does is he goes to see Fred the next morning and says, Fred, man, you know, I relapsed last night and my parole officer is going to find it out because I have to do a P-test today. And, you know, if I don't get into treatment, they're going to send me back to jail. And so Fred spends 24 hours trying to get him into treatment, and guess what? There's no place for him. So guess what? He goes back to jail. So we have this circular thing also where if we aren't there to support people with these support systems, we're shooting ourselves in the foot.
Thank you for saying that. It led to a question we got that was quite profound from one of you here who has a 27-year-old daughter, a semester away from a degree in engineering, was incarcerated at the Chittenden Women's Correctional Facility for 21 days waiting for a treatment bed. The mental health system was unable to commit her to a hospital even if a bed was available because she is bright and knows how to answer the screening questions. And he wonders why the state of Vermont, what sort of incarceration treatment they provide. Maybe you could help us with that, talk about correction issues.
Sure. The corrections has done great work in trying to provide programming for individuals that are either struggling with addiction or not. There's a lot of programs, the risk reduction programming model that they're doing, more so in the probation offices. But they also have healthcare provider that provides mental health and substance abuse services. I do agree that there needs to be more services within the facilities. I think over time it's ebbed and flowed where there's been more substance abuse treatment within the facilities, more groups available. There's been more mental health options for them, and that over time it's ebbed and flowed. I think that the department has put a lot of effort into the programming within the field, but that's not necessarily reflective of what's happening within the correctional facilities as well. So once people are inside, they have caseworkers, and they also have sometimes probation officers that can work jointly together. When they do talk and when they're working together, they're able to get them into residential level of cares if they're needing that. So not all the work is needing to happen within the correctional facilities. They're doing work to then place them within the residential facilities. But that doesn't necessarily mean that there's openings in the residential facilities. So sometimes the Department of Corrections is this holding pattern for these folks that they don't need to be there in jail. What they're really needing is treatment. However, it's sometimes safer for people to be incarcerated for a short period of time while they're awaiting a residential placement. So I think it's a really hard balance of protecting themselves or the department helping to keep themselves safe, the people incarcerated safe, the community safe, while they're being waiting to get into a residential facility.
You know, on the other hand, it seems incredible the amount of drugs in the jails.
I think we had mentioned diversion. I mean, that is clear, a clear picture of how diversion happens and where it's landing. Just because somebody's in a controlled environment doesn't mean that addiction ceases and that it stops. It's in the facilities as well, absolutely.
Mm-hmm.
Can I also touch on that
Please.
for a second?
Yeah.
And I don't think he'll mind. My fiance is in the audience, and he was incarcerated for 18 months. He's also in recovery and celebrating a 4-year anniversary coming in September.
Yeah.
Adam went into prison when he was 6 months sober. He went through an outpatient program through the Claire Martin Center, graduated, and due to what he had done in his active days, he spent 18 months in there. And the conversations that I remember having with him on the phone were, I was like, I don't even know how he was able to stay sober in there because of the things that he saw. I can't even fathom it. But then to have him get out, and Renee and I were just actually talking about this before this started, your desire and your want has to be really, really strong to have like that perfect no relapse kind of thing. I have not relapsed, and I'm thankful for that. He hasn't, that I know of. I don't know what happens in jail, but I trust and believe that he has stayed sober, and we've been together for 3 years. And we've lived a sober life with 2 kids, you know, and we're living life on a quote unquote normal scale, you know, we're doing the house thing, we're being parents, going to work every day and earning a living, you know, like, and those are our desires, those are our wants. So the desire has to be big. The last thing that I want to say before I end is that if I did not have a sober house to go to after, and my family, who has been a huge support for me, I'm blessed that I come from a family that was supportive and didn't use, you know, my sister's a different story, but like my mom and my grandparents, I come from a really well-respected family, and they were very supportive and clean. You know, my grandmother took the wine out of the house, you know, she did a bunch of different things for me, but I had over $300 in my pocket, on a card really, when I left rehab. And I was about to call. My mother was irate with me because I didn't want her to come pick me up, because I was trying to get a dealer to come and pick me up. Then in return, I had one of my friends who then brought me and another one of my friends to the sober house. She was going to the same sober house. The support system is huge. Surrounding yourself with people who want the same thing as you is huge. And if that's something you want, is being sober and living life on life's terms, you have to surround yourself with those people that do the same thing. So I can so relate to what you had said earlier as well.
So I want to pick up with what you were talking about, what's missing, and how, for example, you talked about wraparound services and things like that. And all of you guys and ladies, you know, are dealing in an area that you have an expertise, and there clearly are things that you see that are missing. So, you know, in the what to do, what's missing? Annie, why don't you start us?
I think housing is absolutely critical. I mean, if you don't have your basic needs and safety, life is absolutely dreadful. And I think it's something that all of us take so much for granted. I worked with homeless youth in Burlington for 20 years, and I don't know how anybody managed to stay in our shelter, because I think sometimes organizations and institutions, while they're well-meaning, and we all had good intentions, create barriers and boundaries with our rules and what people need to comply with, and I probably would have flunked out of my own program. But that being said, I think the stressors of being homeless and not having meaning in your life and having any direction and not being able to envision anything for yourself tied to self-esteem, etc., is just another crippling aspect. I mean, a lot of research has also been done even for the incarcerated population of the special type of incarcerated PTSD that people get from being institutionalized. I think even upon exit, they also suffer from that type of condition and those kinds of challenges. So I think for me, it's access to what we would assume everybody in our state and everybody in our nation should have, which is safety and well-being in terms of protected place and people to be with.
Yep.
I need to piggyback
Connection.
on that, is that those basic needs need to be met. Within Claire Martin Center, we have a reentry coordinator who focuses on those. So people coming out of incarceration or on probation and parole, we have somebody specifically able to work with these individuals who need just basic skills, needs, clothing. They're getting released from incarceration with nothing to wear other than what they're walking out with. If they don't have those basic needs met, they're not going to be able to focus on recovery. They're not going to be able to focus on the next meeting that they have to hit. So it's those basic needs. I also think as professionals that a need that we have is to step out of our silos. We get into this mindset of this is our role and this is what we need to do. I'm a treatment provider and this is all I can focus on, where we need to step outside of that and we need to be working together collaboratively. And if we're not talking to each other, we are not doing any justice for the clients that are walking through our doors.
How do you do that?
Talking, having a dialogue, talking to the prescribing doctor, talking to the sober house, talking to Sheila, talking to all the people that are in their recovery environments. So if as a provider, you're not picking up the phone to talk to their supports, then you're not doing your job. So I think it's as simple as a conversation.
So, yeah, I think I've been mentally hopping up and down in my chair this whole time. I know it hasn't been obvious. But I think there are maybe 5 or 6 determinants to an outcome for any chronic disease, any disease, not just addiction. And some of the determinants are things like poverty or socioeconomic status. Some of them have to do with like family and social support. So if you have those things or aren't struggling in those things, whether it's the outcome of a surgery, cancer, or addiction treatment, it turns out those things matter, right? If you have a spiritual connection, it turns out that matters. That's associated with a better outcome. If you're motivated, if you have good insurance, that matters. So from where I sit, and oh, by the way, the quality of the treatment you get also matters.
Yeah.
So, and that is true for all kind of diseases, not just addiction as well. So I guess my point is some of those things are really important, and I don't want to be accused of silo thinking, but I think we need to make sure that the quality of treatment that's afforded people is the best it can possibly be, much like we would with any other medical condition. So just a story, I prior to coming to New Hampshire, I worked in Chicago with the National Football League and with the addicted physicians. These are people who aren't in poverty, who many of whom have pretty good social support. They got reasonably good jobs. I mean, to some extent, the football players are unstable in their work, depending on the quality of their play. But a lot of these things that we're housing, they've got housing, but the variability in their outcomes was determined a lot by the quality of treatment they got. Not just by their socioeconomic status, their educational level, the amount of money they made, the cool houses and cars they had, but the quality of treatment. So I think we just can't assume that by offering treatment, that's going to be the answer. The treatment has to be damn good, and it has to be the best treatment available. And I think partly because of the assumption that these are poor people, these are people who just need to get their act together, that they're not afforded the same kind of treatment, the same kind of insurance benefit, the same kind of understanding that other people get. So I think that's huge.
Yeah.